Hi, good morning. It's nice to wake up this morning to a sunny sky. It was a 7.5-hour drive from New York last night. So I'm glad to see all your smiling faces. We'll see if you're smiling by the time I finish this co-infection talk. I'm going to discuss with you this morning a problem which is really, I think, one of the major problems patients stay sick with Lyme disease. I think many of you probably know that the ticks are containing multiple infections. And the problem that I face at this point, as Marilyn told you, is I've seen over 12,000 chronically ill people with Lyme, but the patients who come to me, they don't just have Lyme. They have Lyme and multiple co-infections. They also have inflammation. They have immune dysfunction, where they may have positive anti-nuclear antibodies and positive rheumatoid factors because their immune system is overstimulated. And they get inflammatory cytokines, these molecules that basically cause inflammation. And it's those same molecules that cause fatigue and headaches and joint pain and memory problems. But the problem is that when these people come in with all of these symptoms, they have a lot of overlapping factors. And I would say on the average, people come to me with at least 3 or 4 co-infections. And I'm going to discuss with you this morning the most important co-infections that I see in my practice. Now, I was driving through Connecticut recently, and I thought it was interesting. I stopped over and I pulled over on the side of the road, and they said, you know, this epidemic for Lyme is getting so bad that now they're naming towns after people who have Lyme disease. So Martha had Lyme disease, Chester had Lyme disease. I don't know, I thought that's a little unusual to be naming towns after people with Lyme. So there's a model I'm going to talk to you about today, and this is really important you understand this because this confusion about what is Lyme disease or what is chronic Lyme disease or what's post-treatment Lyme disease. There are all these names to describe people who come in who are chronically ill. And the problem is that we learn in medical school this model called Pasteur's postulate. And Pasteur's postulate is that there's one cause for one disease. So you would think if someone came in with Lyme disease and they don't get better because you give them treatment for Lyme, that must be because your treatment didn't work. That was the conclusion that the Infectious Disease Society of America came up with these 4 double-blind studies. Well, in fact, 2 of those double-blind studies, the people did get better. The Krupp study, the fatigue got better. And Brian Fallon's study, the encephalopathy and the fatigue and joint pain got better. But even in Fallon's study, he found that 60% of the people had Bartonella, cat scratch fever. And in some of those patients who didn't respond to IV Rocephin, when you give them things like doxy and rifampin or zithro-rifampin, which are Bartonella regimens, lo and behold, they get better. So when your patient comes into you and they say to you, Doc, I'm tired. I have good and bad days. My symptoms come and go. I have joint pains that move around my body. One day it's in one joint, and 2 days later it's in my knees, and 3 days later it's in my ankles. And I've got this tingling numbness and burning sensation that's also migrating and moving around my body. And I've got a stiff neck and a headache, light sensitivity, sound sensitivity. My memory's terrible. I have memory concentration problems. I walk into a room and I can't remember why I'm walking in. I'm forgetting people's names and phone numbers. I'm depressed. I'm anxious. I can't fall asleep at night. I keep waking up in the middle of the night. I have chest pain. I have palpitations. And I have day sweats, night sweats, and chills. And I can't catch my breath. Do any of you in the audience know what the day sweats, night sweats, and chills are? Please yell it out. Babesia, that is correct. The patients who come to see me usually have Babesia, which makes their Lyme symptoms 3 times worse. You will not get over Lyme disease if you do not treat these co-infections. Babesia specifically is one of the worst. When initially the JAMA study came out by Krauss back in 1996, he found that they were able to find Borrelia PCRs, the DNA of Borrelia, 3 times more frequently in the blood when they had Babesia. It suppresses the immune system. All of your symptoms are worse with these co-infections. So let's say a Lyme patient also comes in and they've got low white cell counts, low platelet counts, leukopenia, thrombocytopenia. Their liver functions are high. What's the co-infection? Ehrlichia, anaplasma, that's correct, whoever yelled that out. Ehrlichia and anaplasma will give you that presentation. Any other co-infections that do it? Rocky Mountain spotted fever, rickettsial infections, okay? And what if that Lyme patient that I was telling you about, that nerve pain, that neuropathy, that tingling, numbness, and burning, it's just horrific. It doesn't get better with classical Lyme therapy. And they've got visual problems. And their encephalopathy, their memory concentration's bad, and they're not responding to Lyme treatment. What could it be? Bartonella, that is correct, whoever yelled that out in the back of the room. Bartonella, cat scratch fever, is not what we learned in med school. It's not these little papules on your hands and then you get swollen lymph nodes. These co-infections, when they get into patients with Lyme, they have a completely different presentation and they will increase the severity of all of your symptoms. So I'm going to talk to you about more this afternoon about this model that I've developed after seeing over 12,000 people in the last 27 years with Lyme disease, and I call this MSIDS. Multiple systemic infectious disease syndrome. And this is like a patient going into a doctor's office with 16 nails in the foot telling you they've got foot pain, and the doctor pulls out one nail for Lyme disease, and they come back a month later and tell you they still have foot pain. That's because you didn't get the other 15 nails. And what we're going to talk about this morning are several of those nails, which are the co-infections, which I will tell you is probably the number one, number two, number three nail that's going to follow Lyme disease as far as why these people are sick. So we need to rename and redefine what we're clinically seeing, because I want you to realize that these patients with chronic Lyme disease, or what I call Lyme MSIDS, and the reason I named it this is for many reasons, but number one is because you must think that there are multiple overlapping factors keeping people ill. And again, I'm going to go into this afternoon, but the co-infections are very important. And the ones we're going to discuss this morning are going to be other bacteria, such as other strains of Borrelia. Now, here's the problem. A patient can come in with a Lyme-like illness, and you've learned that Lyme is Borrelia burgdorferi, usually sensu stricto. But there's 100 different forms of Borrelia in the US and 300 different strains worldwide. In fact, there's one that's showing up now in New York, in San Francisco, in Canada, that will give you erythema migrans rashes, and it will give you a Bell's palsy, and it will give you an encephalitis, and it's not Lyme disease. Does anybody know the co-infection? What Borrelia species is it that's starting to emerge? Borrelia miyamotoi, the relapsing fever Borrelia from Japan. You get 2 points right there. So we're going to talk about today the fact that there are also Borrelia species. Kerry Clark from Florida just did a study that was just published that he found all these different Borrelia species in Florida, in Virginia, in the southern states. 42% of the ticks contained other Borrelia species, and they were not all Borrelia burgdorferi. They're not all going to test positive on the two-tiered test of an ELISA followed by a Western blot. So the problem is these Borrelia species can give you a Lyme-like illness, but you're not going to test positive. So you need to understand things like, how do you interpret a Western blot? The Western blot in the United States is the B31 strain. That's what LabCorp and Quest are using, but if you've got 100 different strains, are you going to pick it up with one strain? No. That's why IGeneX uses the 297 strain from California, from Connecticut, because when you put them together, the bands on the Western blot show up much more clearly. So I tell this to my patient, I call it Lyme bingo. I say, if you've got any of these bands on a Western blot, the 23, the OSP-C, the 31, the OSP-A, the 34, the OSP-B, the 39, and the 8393, if you're a patient who comes in and says, I have good and bad days, and it's coming and going, and I take an antibiotic, and my fibromyalgia, chronic fatigue is much better, or much worse from a Herxheimer reaction, inflammatory cytokine release, or you're a woman right before, during, or after your menstrual cycle, you're saying my symptoms are much worse, right? And your joint pain, muscle pain, and nerve pain are migrating around your body, and you've got any one of those bands on a Western blot, bingo, you have Lyme disease, or at least a Lyme-like illness. Because I'm also going to show you another EM rash. Lyme causes EM rashes. We now just learned that Borrelia miyamotoi causes EM rashes. What's the third one that looks like an EM rash? And by the way, you're going to find this morning, I'm going to keep repeating this for you. So by the time you leave here this morning, you'll really get it. What's the third organism, the third disease that causes an EM rash? Star eye. Southern tick-associated rash-like illness in the Midwest, in the Missouri area. They don't know exactly the Borrelia species. They've called it Borrelia lone star eye. Nobody exactly knows. Supposedly it's milder, although the people in Missouri will tell you not absolutely true. So the point is, this morning what we're going to discuss is these other bacteria, other Borrelia, Anaplasma, Ehrlichia, rickettsial species, Bartonella, tularemia, brucellosis. All of these different types of infections are getting into your patients. How do I know? I have patients from Maryland who come to see me all the time. They come from Florida, they come from Canada, they come from Europe. I've had European patients come to me with Babesia WA1. It's a strain of Babesia, this malaria organism, not known in Europe. I mean, people know it should be there, but the doctors never test for it. I recently had a French patient just call me up 2 days ago. We did a phone consult. After just 1 month of being on an anti-malarial regimen with Mepron and Zithromax, he'd suffered for 5 years in France. Most of his Lyme symptoms were better because I treated his malaria organism, the Babesia WA1. So bacteria, viruses, parasites are all inside the ticks. And there's a virus that causes Ehrlichia and Anaplasma to kind of looks like a similar syndrome. Do you know what the virus is that causes a similar type of syndrome with low white cell counts, low platelet counts, and elevated liver functions? The Heartland virus, also discovered in the Midwest, except that virus will not respond to doxycycline. So sounds like there's a lot here, but if you break it down, you'll find there's a lot of overlapping common denominators. We can really understand how these co-infections cause people to be ill. But the main point at the bottom of this slide is if you treat what I call the 3 I's, infection, inflammation, and immune dysfunction, you're going to find that people will ultimately feel much better and their chronic illness will get better. So how frequent do we find these co-infections in ticks? Well, actually, they're quite frequent. In New York, where I live, they did a study by Tokars back in 2009, and they found that 30% of the ticks had a polymicrobial infection. So they had Borrelia burgdorferi. There's that relapsing fever spirochete, Borrelia miyamotoi. This goes back to 2009. Now, by the way, they're finding more and more of this across the US. I'll talk to this in just a little bit. Anaplasma, Babesia, and Powassan virus. Now, I was the first doctor in New York State to discover Babesia in the Hudson Valley where I live. There was a woman who came in to see me who was in a wheelchair for 5 to 6 years with chronic Lyme. And she was 31, 32 years old. She had drenching night sweats. You're a doctor, you do a differential. What's the differential diagnosis in a 31-year-old woman with drenching night sweats? You got hyperthyroidism, you've got tuberculosis, but there was no cough, there was no hemoptysis. There was no swollen lymph nodes. She didn't have non-Hodgkin's lymphoma. She still had a period. She was not postmenopausal. She never went outside the country. She didn't have malaria, right? There's only a certain number of things that cause drenching sweats. She had Babesia. And within 10 days of giving her Mepron and Zithromax, this woman walked out of a wheelchair for the first time in 6 years. She cost New York State over $500,000 in disability. And basically, she's skiing at this point in time because I treated a co-infection. So please realize these co-infections are one of the major reasons that people don't get better. And we're also now finding Powassan virus. Now, Powassan virus is problematic because this can be deadly in 15 to 30% of the cases. So 10 to 15% on the average, but Gary Wormser, there's a study that he's actually looking at right now, it's up to 30%. And with a tick bite, within 15 minutes of a tick bite, you can get a Powassan virus inside your body. So this is not the same thing if you need a tick on you for hours and hours. And Powassan virus is now spreading, and I'm going to show you how quickly these co-infections are rising. They're now finding Borrelia, Ehrlichia, and Bartonella, that cat scratch fever. It's in the Midwest. They're finding WA1 Babesia in Europe. It's in the literature, but the doctors over there don't know about it. And then they're finding a lot of viral encephalitis also in Europe. Here again, they're finding Bartonella in the Midwest. It's in mice. They're finding it in New Jersey in patients who have encephalitis, where they've got a lot of memory concentration problems, brain fog, headaches, they don't get better. They're finding Bartonella henselae cat scratch fever in the central nervous system. And one of my patients who presented with a transverse myelitis, he couldn't walk, he had seen 8 neurologists. We did a spinal tap and it was positive for Bartonella, and again, within treating him for Bartonella and Lyme, he started walking for the first time. The Bartonella was causing the demyelination, was causing this inflammatory reaction, and it was not enough to treat the Lyme. You had to treat the Lyme and the Bartonella, or the Lyme and the Babesia. right? So you understand the co-infections are very important. And finally, mycoplasma. Eva Shoppe at the University of New Haven has been doing a study, and I helped her a bit with it. And we're looking to get this published, but she's finding mycoplasma species in ticks, like Mycoplasma fermentans, the organism that causes Gulf War syndrome, Mycoplasma pneumoniae, and Mycoplasma genitalium. Now, the reason this is important is the one common denominator that I'm going to share with you, I'll talk about in detail this afternoon, is inflammation. Mycoplasma species can really rev up the inflammation in the body, causing TNF-alpha, interleukin-1, IL-6, a lot of inflammatory molecules to be produced. And that may be, by the way, when a rheumatologist gives a patient Plaquenil and minocycline for rheumatoid arthritis or for a very bad type of arthritis and said it's a DMARD regimen, it's anti-inflammatory, it could be that the minocycline is actually affecting mycoplasma, which is driving tremendous amounts of inflammation in the body. These co-infections are rising very rapidly. Even if you do not have certain co-infections in your area 3 or 4 years ago, you may have them now. They've been isolating the Powassan virus, the deer tick virus, now from Ixodes ticks in our area. Recently, they tested 13,000 ticks, and the rates were up to 5 to 6% of infected adults. Now, to put that in perspective, several years ago, only 1 to 2% of the ticks had Powassan virus in my area. That means it tripled within 4 years. Take a look at the Vermont study. Increased incidence of triple E, equine encephalitis virus, in 10% of the ticks that are being found on the deer. The Vermont Department of Health did a study and found that 16% of the dogs in Vermont had Lyme disease. Well, if 16% of the people in Vermont had Lyme disease, and I presented at Congress for Vermont several years ago to their House and Senate, there's 675,000 people in Vermont. You figure out that they've got a certain amount for their healthcare budget, it would be about $1 billion per year to treat Lyme disease if 16% of the Vermont people had Lyme. There's also a study that came out in the Banfield Vet Department. I don't know if you saw this. This came out about a month ago. Banfield hospitals, they're veterinarians across the US. They have like 1,000 different centers across the US. The dogs in the United States, the rates of Lyme disease went up by 21% in 2013. We are in the middle of an epidemic that is spreading rapidly with blood tests that are unreliable. The ELISA test only picks it up in 56% of the cases in the British Medical Journal study that was done by Stricker back several years ago. So we've got a big problem on our hand. You must know how to diagnose Lyme clinically, and you must understand how these co-infections present, because it's really the key to getting these people better. Also in Vermont, the increased incidence of anaplasma, we saw there it doubled from 0.9 to 1.8%. And now we're finding Borrelia miyamotoi rates that are also going up. Yale just published a study last week that they found in New England, 10% of the people were testing positive for Lyme. Now, to put that in perspective, when the CDC did the studies 2 years ago by Hook, and they said that 0.3% of the American population had Lyme, you may have heard it went up tenfold, from 30 to 300,000. Well, if you look at the Hook study, it was 0.3% of the American population. That's close to 1 million people. But they were using two-tiered testing in 60% of those people, which missed half of them. And then they didn't include the people with chronic fatigue, fibro, and multiple sclerosis, who are major overlaps for Lyme as the great imitator. They didn't include New York. You're looking at basically probably 2 to 3 million people a year, in my estimate, that are getting this, and the co-infections are right behind. Don't just think this is an epidemic of Lyme. Borrelia miyamotoi they found in 4% of the people in New England at the same point they found Lyme, and there is no reliable test for Borrelia miyamotoi. Now, I had my first positive test, PCR, for Borrelia miyamotoi several months ago. Bob, you'll probably enjoy this one. It was a patient with psychosis. He presented with schizophrenia for several months. We did a PCR in his blood, and it was positive for Borrelia miyamotoi after being treated, by the way, for several months of antibiotics. This is Milford Hospital Laboratory. And the same lab, also in one of my patients, found Borrelia burgdorferi, Lyme. This woman came in to see me for a consult. She had been on antibiotics for 5 years before seeing me. Her PCR was positive in her blood for Borrelia burgdorferi, for Lyme disease, from Milford Labs. These are chronic, persistent infections. Lyme persists if it's not caught early. You can cure Lyme in 75 to 80% of the cases if you catch it within the first 30 days. Afterwards, it is a persistent infection. But the same problem with the co-infections. Babesia persists. Bartonella persists. Mycoplasma persists. How do I know? I've had patients with positive PCRs in their bloods years after treatment, and I'll show you some of the studies on these with Babesia later on. So Ehrlichia, we just talked about this. A patient comes in, it's in the summertime. They've got a stiff neck, they have a horrible headache, high fevers, muscle aches all over the body. You send them in for a CBC, white cell counts low, leukopenia, platelet counts low, thrombocytopenia, liver functions are high. Classic Ehrlichia. But again, I'm going to cross-reference for you Ehrlichia, anaplasma, and rickettsial infections like Rocky Mountain spotted fever will cause the same type of presentation. Now, why do you want to get these people on a tetracycline as soon as possible? It's deadly in the very young and in the very old. So if you're immunosuppressed, you're young or you're old, you want to get these people on doxycycline immediately because there have been deaths. In fact, if you look at the Department of Health statistics, there have been more deaths from co-infections than there have for Lyme. When they started reporting the Lyme carditis a few months ago about all of the heart problems, take a look at the studies on anaplasma, Babesia, and the rest. You'll see that the rates were actually even higher for morbidity and mortality. So you want to get them on tetracyclines as soon as possible because even for Rocky Mountain spotted fever, that rash may not appear. It only presents in 40 to 60% of the cases days later after they've had their bite. If you've got a very young child and you're worried about them, giving them tetracyclines because it can stain the teeth below 8 years old, or people are allergic, you can give them rifampin. And I found that sometimes double intracellular drugs like zithro-rifampin, excellent regimens for some of these intracellular co-infections. Now, I'm going to share with you this morning, I told you that Lyme has all these different species. There's 100 different species of Borrelia in the United States. Well, it's no different for Ehrlichia. It's no different for Babesia. It's no different for Bartonella. Many of these co-infections, the reason you won't find them on some of the standard testing is because there are so many different species, you can't pick all of them up on the same testing. And that's why you've got to look for that low white cell count, low platelet count, elevated liver functions with the classical symptoms for it. Because you can get Ehrlichia species such as HSC, HGA, HME, HEE, and a newly discovered HWME, which are anaplasma, phagocytophilum, Ehrlichia chafensis, Ehrlichia owingi, and Ehrlichia Wisconsin, Minnesota. And there's no specific test for Ehrlichia windi, and you can get false positive tests on some of these patients with other co-infections. And I published this with Dr. Shah 2 years ago. And some of these co-infections are now in the blood supply. So you can get anaplasma and you can get Babesia through a blood transfusion. And this is problematic because the Red Cross, I've spoken to them about it, we have no reliable screening that's going on at this point in the blood supply in the United States. So, I said to you before that there is a virus that kind of looks like Ehrlichia and anaplasma, and it's called the Heartland virus. It's a phlebivirus. It was published in the New England Journal of Medicine back in 2012. It looks like Ehrlichia, but it's transmitted not by the Redefining species, by the Lone Star tick, by Ambyloma americanum. And this can cause fatigue, fever, loss of appetite, and non-bloody diarrhea. Now, one of the things that's interesting about these co-infections I want to share with you, if a patient comes into you and says, "Doc, I got nausea, I got vomiting, and I've got diarrhea," what does a doctor normally think of? You've got a virus. Ehrlichiosis can cause diarrhea. You can get diarrhea with any other co-infections, anyone know? Rocky Mountain spotted fever will cause diarrhea. Tularemia, typhoidal forms will cause diarrhea. So many of these co-infections, including even Lyme in the early stage, in early Lyme, you can get nausea and vomiting. So just know that the gastrointestinal symptoms that you'll sometimes think are a virus can also be due to Lyme and co-infections. So the lab values look like Ehrlichia for the Heartland virus, but it will not respond to doxycycline. And this is only one of several viruses that are now in ticks. So the ones that we're going to generally see in the United States will be the Heartland virus and the Powassan virus, but you should know there are other tick-borne encephalitis viruses. For example, Omsk hemorrhagic fever Cancer forest disease, Congo Crimean hemorrhagic fever, things you've never heard of are tick-borne viral infections. Not where we are at this point, but ticks contain viruses. They contain multiple bacteria and they contain parasites. So always think tick bite, you can get different organisms transmitted with the same bite. Now here's Borrelia miyamotoi, this relapsing fever species that we talked about. Why should we be concerned about Borrelia miyamotoi? Well, it's the first Borrelia species that's been shown that the mother tick can transmit this organism directly into the eggs transovarily. They don't need to feed off a mouse or a deer to be able to get this organism. And they found that 6 to 73% of the larvae of infected female deer ticks have been infected. This means that you're going to see an epidemic of Borrelia miyamotoi, which is probably going to outpace and outrun Lyme in the next 5 to 10 years. So, where did they just pick it up? Well, we picked it up in New York. They just found it in the parks in San Francisco, which means it has spread throughout the entire United States. They just found it in Canada in less than 0.1% of the ticks. And that's because the birds are carrying the ticks to different parts of the world at this point. There's no reliable blood test. You cannot count on an ELISA or a Western blot to pick up Borrelia miyamotoi, and it could explain resistant symptoms in your patient who sound like Lyme. They've got a Lyme-like illness, but basically it's not that particular species of Borrelia burgdorferi. It's another species like Borrelia miyamotoi, or as Kerry Clark just found in Florida, Borrelia americanum, or other Borrelia species that can be responsible. Now in Europe, they've got Borrelia valsana, Borrelia lusitania, Borrelia afzelii causing acrodermatitis, chronic atrophicans, these skin rashes, which we have a bit in the US. That's not Borrelia burgdorferi, it's Borrelia afzelii. Or they've got Borrelia guerini, which causes neuroborreliosis in Europe. Not Borrelia burgdorferi, all with different, slightly different clinical presentations, because these different Borrelia species will cause different inflammatory responses in the body. And that's where I was telling you there's 3 different types of organisms that can cause EM rashes. The great imitator, Lyme disease, Borrelia miyamotoi, and star eye all can cause this type of a presentation. And again, remember, half of the patients don't present with bullseye rashes, and of the ones who do get them, it's only somewhere between 15 to 25% that actually get EM rashes. And this is from the SmithKline-Beecham studies that were done years ago. So do not count on a bullseye rash to be able to tell if someone has Lyme. Now, I don't need you to go through this whole slide, so just kind of grab onto me and just listen to me as to what this is. A patient comes in, I want to teach you differential diagnosis. Patient comes in with 103, 104 fever with drenching sweats. Borrelia miyamotoi causes it. What's the next organism that's going to cause high fevers and drenching sweats that we just talked about? Babesia, right? Malaria-type organism. So, relapsing fever. Now, there's also Borrelia hermsii. And interestingly enough, I'm going to ask you to do something in your medical practices. Go test your patients through LabCorp Quest for Borrelia hermsii. And tell me how many positive cases you get. About 25% of my cases, of every Lyme case that comes into the office, has positive titers for relapsing fever Borrelia hermsii. I have not published this yet. We're looking at all the studies right now. So, drenching sweats, fevers, headaches, fatigue, joint pain. Well, that's kind of nonspecific. You can't really tell. That could be a virus, it could be Lyme. Look at the gastrointestinal symptoms. Again, nausea, vomiting, abdominal pain. You might think it's a virus. It can be relapsing fever. Hepatitis. You might think Hep B, Hep C, Hep A, hemochromatosis, iron overload, copper overload, Wilson's disease, alpha-1 antitrypsin deficiency, right? Get your differential diagnoses for hepatitis. But so does Borrelia miyamotoi cause a hepatitis-type reaction. What's the other co-infection that causes hepatitis, that can cause a chronic hepatitis? Q fever, Coxiella burnetii. It's a rickettsial infection like Rocky Mountain spotted fever. It will cause a chronic hepatitis. So now we're learning that just viruses don't just cause hepatitis. Relapsing fever causes hepatitis. One of my patients who came to me a month ago had elevated liver functions with an AST/ALT in the 300-400 range. We ruled him out for everything else. I put him on doxycycline, and they all went down to normal. It was actually Lyme. And he's the first case I've actually seen like this in years. So tick-borne infections can cause a hepatitis when you've ruled out every other cause. Hepatosplenomegaly. What other co-infection causes your spleen to enlarge and your liver to get a bit big? Babesia. You can get enlarged spleens with Babesia, and if you happen to have someone who's had their spleen removed, they're in big trouble when they get Babesia, because the spleen is one of the major ways you remove this parasite from the body. But look at the central nervous system, meningoencephalitis, just like Lyme disease, a meningitis, encephalitis, Bell's palsy, not from Lyme, from Borrelia miyamotoi. So would you expect on a spinal tap, spinal taps are only positive in 7% of the people with central nervous system Lyme disease. You're going to pick up Lyme disease on a spinal tap? Often no. What about Borrelia miyamotoi? What if you suspect they have Lyme with a Bell's palsy and you're trying to do a tap? You're not going to pick up Borrelia miyamotoi. You'd have to be lucky to get it by a PCR. And it would have to go to Milford Labs because the labs are not generally doing it at this point in time in the United States. Myocarditis, inflammation of the heart. These tick-borne co-infections affect the heart. They can cause an effect on all the different layers of the heart: endocarditis, myocarditis, pericarditis. Every layer of the heart can be affected by tick-borne diseases like Lyme and Lyme-like organisms like Borrelia miyamotoi. And here's one that would be a bit unusual: ARDS. Patient comes into the emergency room, they can't breathe, you do a chest x-ray and it's whited out. You've got ARDS. Borrelia miyamotoi? Yes. What's the other organism, tick-borne co-infection, that causes ARDS? Babesia. Published in the medical literature, Babesia will also cause an ARDS-type presentation. Now, the reason I'm doing this for you, going back and forth with the co-infections, is to show you the overlaps. That if you're going to learn these, and you need to learn them, because this is why the people are staying sick, and this is why your tests in part will not be reliable and you're not going to pick these up. You've got to learn the multiple clinical manifestations, but there's a big overlap, and as long as you understand, oh, ARDS, oh yeah, Dr. Horowitz talked to me about that, Borrelia miyamotoi, Babesia. Oh yeah, hepatitis. Oh yeah, I ruled them out for hepatitis B and C and the rest. Oh yeah, tick-borne infections. Like Lyme will cause it, Borrelia miyamotoi will cause it, Q fever will cause it. Right? You've got to start expanding out your differentials when you're dealing with these chronically ill people. Disseminated intravascular coagulation. Someone starts to bleed out, and they even have a stroke with Borrelia miyamotoi. So the problem is it's the great imitator, just like Lyme. You would never think that this would be a tick-borne co-infections. You even get these different type of skin rashes, which can be macular, little petechiae, little red dots in different parts of the body. Erythema multiforme, which we don't even usually think, it's not erythema migrans. Erythema multiforme, where there's like 100 different things that cause it, can be seen with relapsing fibrous spirochetes. So you're really not going to have an easy time picking this up, although again, this Yale study published just last week, they're now looking at antibodies against Borrelia miyamotoi, so this probably will be coming out commercially at some point in the near future. Now, some patients will recover with relapsing fever, but the whole point of relapsing fever is Borrelia organisms have outer surface proteins, and what they do is they change every few weeks. That's why they try and change them so your immune system can't recognize it. So what happens is that's why you keep getting these recurrent fevers, is because it goes into hiding, it changes the outer surface proteins, and then it starts recurring again. So Lyme disease, and so will be Borrelia miyamotoi. But you can get fatalities from hemorrhage, from DIC, from a stroke, from ARDS, severe Herxheimer reactions that are so bad it can affect the heart. And for women, the reason we need to start screening pregnant women in the United States before they get pregnant, Lyme can be transmitted to the fetus. Borrelia miyamotoi can cause fetal death. Bartonella, cat scratch fever, can be transmitted to the fetus and cause fetal death and abnormalities. Rickettsial infections can be transmitted, and the OBGYNs are generally not screening women for these co-infections. So there's a questionnaire that I'm going to talk to you about this afternoon, which is a screening questionnaire. Anyone who wants to use this questionnaire and enter into a clinical study we're doing, to score it. In our office, a score of 46 or higher was 2 standard deviations above the mean, and we found that this would predict whether you had Lyme MSIDs, Lyme, and co-infections. So tetracyclines can be used early on, and IV Rocephin, just like you would for Lyme, if you've got central nervous system disease. Star eye, I don't need to spend a lot of time with because you're not really going to see much of it here, but just know that it's an EM rash like we talked about, looks like Lyme, don't know the Borrelia species, maybe mild or arthritic symptoms. Again, I've been to Missouri. If you speak to the people there, they'll tell you that it's not so mild, but it's not Ixodes scapularis, it's Ambyloma americanum. It is the Lone Star tick. So you're going to get negative Lyme testing. Now, what's interesting about this is I knew Ed Masters. Many of you have never had the pleasure and the privilege of meeting Ed Masters. He was a fabulous physician in Missouri who was the first one to discuss this. They call star eye Masters disease. I looked at his studies that he published on star eye, and you'll notice that although it's said by some of the infectious disease doctors that we don't think it's a Borrelia species, if you look at the studies that Masters did, you're going to notice that almost every band on the Western blot that I told you about for Lyme shows up in patients with star eye. The OSP-C, the OSP-A, you're going to find the same bands on there. These are Borrelia species, which have these very specific outer surface proteins. So you're going to treat them with tetracyclines, treat them as if they contracted Lyme, and without treatment, 10% experience recurrences. So it may be a slightly milder form. And again, I told you there's 100 different species of Borrelia in the US. They all will have slightly different clinical presentations. Borrelia afzelii in Europe and here, this violaceous skin rash, acrodermatitis chronica matrophicans, Guarinia's neuroborreliosis. Maybe another Borrelia species, Borrelia lone star eye, is star eye. So know these different Borrelia species have different clinical presentations. Okay, let's talk about Babesia. Anyone who comes into your office with malaria-type illness, you must ask every patient who comes to see you, and this is why I recommend you use the screening questionnaire I'm going to talk to you about later today. The first question on the questionnaire is, do you have day sweats, night sweats, fevers, chills? Do you have air hunger where you can't catch your breath, a cough that you can't explain? If you've got unexplained cough and air hunger, and again, you've done this differential diagnosis I told you about, hyperthyroidism, non-Hodgkin's lymphoma, tuberculosis, you've ruled out causes of drenching sweats, you have to think Babesia. Now, here's the problem. Babesia makes the Lyme patients 3 times worse. Almost every chronic Lyme patient I've seen in my practice at this point has Babesia. But they don't just have Babesia microti. Just like I told you, there's 100 strains of Lyme, there's 100 different pyroplasms. Babesia organisms are known as pyroplasms. It's the general class of how they're known. So the ones we generally see in the United States is Babesia microti and Babesia duncani WA1. That comes from Washington State. 19% of my patients who come to me from Winter Park, Florida, through Maryland, to New York, all the way up to Maine, test positive for Babesia duncani. If you say, I found a patient with day sweats, night sweats, and chills, I know they have Babesia, but you do the Babesia microti test. You do an IFA, an immunofluorescent antibody, and it's negative. You do a Giemsa stain. You look under the microscope to try and find it. You don't see it. That's what you're taught in medical school in the textbooks. You will only find a positive Giemsa stain if the level of parasites in the blood is greater than 5%. You have to have a very high level of parasitemia to get a positive Giemsa stain. Otherwise, you're not going to pick it up. So we've got all these different Babesia species. And in Europe, they've got Babesia divergens. Now, again, you read the medical textbooks, they're going to tell you you should have hemolytic anemia. You should have thrombocytopenia. You should have renal failure. I've never seen one case in my practice of a Lyme Babesia patient who has that clinical presentation. In Europe, however, with Babesia divergens, they have it. Now, that doesn't mean you can't get it. It just means that when Lyme is mixed with co-infections, they start to act differently. You get these subclinical presentations. So when the IDSA published these double-blind studies, what did they discuss in these studies? They discussed Lyme disease. What do the patients come in who see me? What do they have? They don't have Lyme disease. They have Lyme, they have Babesia, they have Ehrlichia, they have anaplasma, they have Bartonella, they have tularemia, they have brucella, they have Q fever, they have all these different co-infections. It was never published in the medical literature. And they have immune dysfunction. They don't fall asleep. If you don't fall asleep, your inflammation doesn't shut off. You get high IL-6. They have zinc deficiency. If you don't take care of zinc, you get inflammation. They have POTS. Their blood pressure's low with autonomic nervous system dysfunction. If you don't get their blood pressure up, they don't get better. None of the factors I'm going to talk to you about this afternoon was addressed in the double-blind placebo-controlled studies, which is why people don't get better. And that's what's in my book, explaining the 16-point map of what I found in patients that's explaining why they stay chronically ill. But Babesia is definitely one of the worst. And if you see a psychiatric case with huge amounts of emotional ability, with depression, anxiety, just horrible psych symptoms, and they've got the sweats, you've got to think Babesia, because Babesia makes all of the neuropsychiatric symptoms much worse. Even the tingling, numbness, and burning, the paresthesias, you'll sometimes treat patients for Babesia, and this is like a Lyme symptom. They'll tell you the tingling, numbness, and burning goes away just from treating their co-infections. So the way you're going to pick this up, you've got to do what's called a Babesia panel. You need Babesia titers for Babesia microti and WA1. Now, WA1 you can get through LabCorp Quest, not a problem. And you can get a microti through LabCorp Quest, but I hardly ever find them positive. I find Digenix Labs is usually much better, but for my Genix, I do what's called a Babesia FISH, fluorescent in situ hybridization. This is an RNA probe where you look under the microscope to find Babesia. Let me show you. That's a Babesia FISH. That's Babesia fluorescing green under the microscope. That has that typical kind of ring form, or in this case, a Maltese cross form, which you see with Babesia. So you want to do a Babesia titer, a Babesia FISH, sometimes a Babesia PCR, looking for the DNA of the organism, because you may have a negative titer, a negative PCR, and a positive FISH. Or you may have a negative microti, negative FISH, negative PCR, and a positive WA1. You have to do the entire Babesia panel, and remember, I'm only screening for 2 Babesia species in 100 pyroplasms. So malaria-like illness, much worse. Realize the tests are not always going to pick it up, but if you give them Mepron and Zithromax, atovaquone and Zithromax, with or without Septra, and they go, wow, my sweats are much better. I feel tremendously better. That's what this French patient told me. I put him on Mepron, Zithromax, and Septra. He was sick for 5 years being treated for Lyme. He is almost 100% better, just being treated for a co-infection for a malaria-like organism. You can also use Malarone, which is atovaquone proguanil. Now, I borrowed most of this from the malaria literature because there's Mepron resistance in the United States. Peter Krause published in this a couple of years ago that we're finding Mepron is not working as well. So if you take a teaspoon twice a day, I find sometimes 2 to 3 teaspoons is necessary, and they cannot take CoQ10 because CoQ10 interferes with the effect of Mepron. But you can use also clindamycin, cliacin, and quinine. Now, I used to joke with patients, the only ones I used to put on cliacin and quinine were the ones I didn't like, because you get nausea, vomiting, ringing in the ears, and rashes in half of these people. It's a really poorly tolerated regimen. But you can do clindamycin and a macrolide. Clinda plus Zithromax, Clinda plus Biaxin. Clinda plus Biaxin and Malarone with Artemisia. You have to mix multiple Babesia regimens. I'm going to do this afternoon for you again and go over this with some of the herbal products. But you've got to mix these if you want to get the Babesia. The classical regimens are just not enough for a lot of these really sick patients. I don't use much Lariam anymore. There's a black box warning at this point. Truthfully, it's a great drug. I've used it in over 1,000 people. Doxycycline and 1 Lariam pill every 5 to 7 days works amazingly well, but the problem is it's got a black box that you can get neuropsychiatric problems or dizziness, so I hardly ever use it anymore at this point. Coartem is a drug that was published in Africa for malaria, 94% success rate. It helps patients with Babesia, not curative. It's a 3-day course of 4 twice a day for 3 days. But the thing that you need to know about Coartem and some of these drugs is QT interval prolongation. You must learn the drugs that will increase your QT intervals: macrolides, Biaxin, Zithromax, quinolones, Cipro, Levaquin, Avalox, Factive will raise QT intervals. You never mix them together. Coartem, Lariam raise QT intervals. Certain PPIs, certain SSRIs can raise QT intervals. So you've got to get your electronic PDR going when you're starting to mix these drugs. And if you're going to put patients on them, do an EKG. They recently found, the New England Journal published, that there were some problems with Zithromax, although a new article just came out that the cardiovascular risks are not quite as high as what we thought, but you definitely should check the QT in some of these people. And then we use herbs like Artemisia, Neem, MCBAB2. I'm going to go through these with you this afternoon. I've never had to do an exchange transfusion at this point, but for some patients who are chronically ill with high level of parasites, it can be necessary. So there's over 100 species of Babesia, as we talked about. While one is rising in the United States, it's now 19% of our practice. And again, it's in the blood supply, as I told you. So really think Babesia. This is the #1 co-infection I see in my patients. So the clinical presentation we talked about: fevers, chills, flushing, day and night sweats. The fevers will come and go, just like malaria. This cough and shortness of breath that you just can't explain. You've ruled them out for asthma, for allergic rhinitis with a postnasal drip, for COPD, interstitial lung disease, right? I'm out of breath, you do your differential diagnosis. If you can't find anything, you have to see whether it's Babesia, and there is the ARDS that we talked about for Borrelia miyamotoi that you'll again see with Babesia. And as I told you, that hemolytic anemia, thrombocytopenia, and kidney failure we really don't see most often, but Babesia divergens in Europe, they will see it much more often than we see in the United States. You have to avoid steroids in these patients. They can reactivate, and there have been cases of death reported in the literature. Same thing with Lyme. You want to avoid prednisone and immunosuppressive drugs as much as possible. Patients will reactivate and get very sick if you give them steroids. And that's why, by the way, if they come in with a rheumatological manifestation and you think they've got lupus or rheumatoid, be real careful whether these patients go on immunosuppressive drugs. Because Lyme can cause false positive rheumatoid factors, and they think it's rheumatoid arthritis. And Lyme can cause false positive anti-nuclear antibodies, and you think it's lupus. I'm going to talk about that this afternoon again. Bartonella, cat scratch fever. Most common co-infection probably after Babesia, making people sick with mycoplasma. We don't get the typical rash and lymphadenopathy, but you can get bad chronic demyelinating neuropathy, radiculitis, myelitis, inflammation in the spinal cord, eye problems, whole different eye problems. If a patient comes in with bizarre eye manifestations, think Lyme, think Bartonella. Because again, an optic neuritis, you can get it with Lyme, you can get it with MS. I'll talk to you about this afternoon on this, on the MS overlaps with Lyme. But you can get the same things with Bartonella. So remember, eye symptoms, Bartonella, especially very bad ones. Like if they have retinal vein occlusion, retinal artery occlusion, just bizarre eye symptoms. Even sarcoidosis. Bartonella will mimic sarcoid. One of my patients came in with increased mediastinal lymph nodes, and the doctor had done a Kvime test down at Mount Sinai, which is classic for sarcoid. It was negative, but they still put him on steroids. It turned out it was Bartonella. When I treated his Bartonella, all of his lymph nodes went away. Now, I told you there's 100 strains of Lyme, at least in the United States. There's 100 pyroplasms for Babesia. Is Bartonella any different? No. I've only listed the top 3 on top here: Bartonella henselae, Bartonella quintana, which is in lice, and Bartonella bacilliformis. There's at least 17 or 20 species that are out there right now of Bartonella. They will not test positive again on the standard testing. This is a nightmare for clinicians. So you have to learn to do clinical medicine in these cases. And the key to make this simple for you is if you have a patient who's very ill, as I said, with bad neuropathy, they're on morphine, they're on Neurontin, they're on Elavil, they're on Cymbalta, they're on Lyrica, they're taking all these neuropathic drugs and they're not getting better. Think Lyme and think Bartonella and think co-infections. I've gotten people off 480 milligrams of morphine sulfate with high-dose drugs by treating the Bartonella and their Babesia. And I don't know how many of you saw when I was on Katie Couric early last year, and you saw the woman in the audience who had chronic inflammatory demyelinating polyneuropathy, CIDP. It's a terrible nerve disorder. I treated her Bartonella and her Babesia, and she came off IVIG, $1 million a year for this therapy, didn't need it. She's now off all therapy, just by treating her co-infections. So, how do you treat these intracellular co-infections like Bartonella, mycoplasma, Q fever, typhus, brucella, all the ones I'm now going to tell you about? 2 intracellular drugs works better than 1. Doxyrifampin, a quinolone like Cipro and a tetracycline, or a tetracycline and a macrolide that hits the 30S and 50S ribosomal subunits and shuts down the bugs. Ceftriaxone Bactrim with a macrolide. If one regimen doesn't work, it doesn't mean you're not hitting it correctly. I have patients, the neuropathy comes back when they stop their doxyrifampin. The minute you put the doxyrifampin back on, their neuropathy is gone. And that same person might not respond to another Bartonella regimen. So you have to rotate the regimens. If one regimen in 30 days, 80% of the time, my patients will get better within 1 month. If you have a regimen that's not working in 1 month, you can wait another month if they're herxing like crazy and you're not sure when they get through the herx if they're going to get better, but you've got to rotate these protocols. And people will come in with these strange rashes sometimes. Now, this actually is not even a classic Bart rash. They're actually perpendicular because this is in the skin planes. But if they come in with these violaceous, what looks like stretch marks, start to think Bartonella. This was Mark and Fried actually published on this years ago. I've tried biopsying this. I couldn't get it, but it is interesting. I'm still not sure it's 100% Bart, but that's what we believe it is at this point. And they do get better. They actually lighten up and will go away when you treat these co-infections. I talked to you about these co-infections can be transmitted transplacentally. So we've got Lyme getting into the fetus. We've got Babesia. We've got rickettsial infections. We've got Bartonella. It's very, very important. If you've got any pregnant women, you need to teach them about tick-borne infections and screen them before pregnancy and make sure they don't have it. Mycoplasma fermentans, this is the organism that causes Gulf War syndrome. I did a retrospective study in my office about 15 years ago. We found 13% of my patients by PCR had Mycoplasma fermentans in their blood. Now, Mycoplasma fermentans is a nasty mycoplasma species. This afternoon, I'm going to talk to you about it a little bit more in detail. What this does is it increases inflammation. So you're not going to pick it up by titers. You can only pick up Mycoplasma pneumoniae by a titers request or LabCorp. You need a PCR for this. And again, just like I talked to you about multiple species, there's multiple mycoplasma species that unless you were to do a mycoplasma panel with all these PCRs, you're not going to pick it up. Double intracellular, just like I talked to you about for Bartonella, works very well for mycoplasma. So why is mycoplasma important? Because in the medical literature, mycoplasma is shown to interact with B lymphocytes, causing autoimmune reactions. They found them increasing pro-inflammatory cytokines, the same inflammatory molecules that give the Lyme patients fatigue, headaches, joint pain, nerve pain, memory, concentration problems, mood swing, can't sleep. Inflammatory cytokines cause those. Mycoplasma drives them. So you'll find in some of these people, by getting the mycoplasma, treating the intracellular infections, let's say a patient doesn't respond to amoxicillin or Ceftin, which doesn't go intracellularly, and they do respond to doxy or rifampin, it could be that you're dealing with mycoplasma, Bartonella, rickettsial infections. Sometimes you don't know what you're treating because the tests are unreliable, but the advantage is if you put double intracellular antibiotics together, you're going to be getting a whole host of these different infections at the same time. We talked about Rocky Mountain spotted fever, right? Nausea, vomiting, fevers, diarrhea. We talked about it, right? Doesn't have to be a virus. It can be Borrelia miyamotoi. It could be Lyme disease. It can be Rocky Mountain spotted fever. And the rash, which is normally on the hands and the feet, will sometimes only show up after the 6th day and only in 35 to 60%, on the palms and the soles 50 to 80%. So the same lab abnormalities I told you about with Ehrlichia, and they're actually genetically pretty much the same. Ehrlichia, Anaplasma, Rocky Mountain, you'll notice low white cell counts, low platelet counts, thrombocytopenia, elevated liver functions. That's why I said to you earlier, if you've got a patient with leukopenia, thrombocytopenia, transaminitis, get them on a tetracycline, because you have possibly a life-threatening disorder in the young or the elderly with a rickettsial infection or Anaplasma Ehrlichia, right? So you'll find that a little bit easier on the tests than you will some of the other co-infections. And again, the alternative treatment we talked about before was rifampin. In this case, it would be chloramphenicol, which, thank God, I've never had to use any time in my life. And a lot of people, by the way, will come in with Rocky Mountain titers and never been treated. So it's very possible the immune system handles this in certain people. Now, Q fever is another rickettsial organism very similar to Rocky Mountain spotted fever. Only half the people show signs of a clinical illness, and there again it is high sweats. So again, we talked about these high fevers and sweats like Babesia, like relapsing fever, nausea, vomiting, diarrhea, hepatitis, even a pneumonia can be Q fever. A meningoencephalitis, Lyme, relapsing fever, Q fever, brucella, a meningoencephalitis, multiple co-infections cause meningitis encephalitis, right? And you can even get a chronic endocarditis 1 to 20 years later. So if you listen to a patient on a clinical exam and you hear a murmur that you can't explain, send them for an echocardiogram, and even better, a transesophageal echo, because you can get acute fever endocarditis. And you've got to run the phase 1, phase 2 titers to see if they change over time. And we've picked up actually quite a few cases of Q fever over time. When you're going to test people for these co-infections, you take out the net and you throw it out just like you would going fishing, and you're going to see what you find, and you are going to be shocked the number of co-infections that you find in your patients who are chronically ill. Same regimens we talked about, double intracellular, doxy and a quinolone, doxy-rifampin. This makes it easy for you, right? All these co-infections, how do I treat them? It's the same basic double intracellular regimen. Makes it very simple. Tularemia, you're not going to see a lot of cases. I've got a great case in my book on this, on a patient who came in with these big ulcers on his leg with swollen lymph nodes, and he had retroperitoneal fibrosis where he shut down his kidneys. They had to put in stents. He went to a university south of here. They had no idea what it was. They thought it was Crohn's. Maybe he had some type of dermatitis. They didn't know what it was. It turned out it was tularemia. He was a chef working with rabbits. And when I treated his tularemia, and this guy, by the way, had migratory joint pains, tingling and numbness, he had Lyme. Doc, I'm 32 years old, I have drenching sweats. He had Babesia, and he also had tularemia. His lymph nodes went away, and I reversed his retroperitoneal fibrosis. His CAT scan's completely clear at this point, and the ulcer's completely closed up on his legs at this point, treating tularemia. So you're not going to get this a lot, but if you get ulceroglandular, big lymph nodes ulcers, tularemia, oculoglandular, conjunctivitis, pus coming out of the eyes with lymph nodes, probably because you touched your finger to your eye with this organism, oculoglandular, and there's even a typhoidal form with diarrhea. So great imitator, Lyme's the great imitator, so is tularemia. So in this particular case, the treatment is usually IVPO doxy, Cipro, again, intracellular, but a lot of times we're going to have to use drugs like gentamicin, which I don't have to use very often, but you will sometimes have to use it. Brucella, again, very rare co-infection. You don't need to know a lot about it, but again, high fevers, drenching sweat. So multiple co-infection cause this with lymph nodes, big liver and spleen, hepatosplenomegaly, pulmonary problems, osteomyelitis, infections in the bone, optic neuritis. Lyme causes optic neuritis. Bartonella causes optic neuritis. Multiple sclerosis causes optic neuritis. Brucella causes optic neuritis. Great imitators. Keep thinking about all these co-infections and how they overlap your symptoms. And again, look below, meningoencephalitis with brucella and an endocarditis just like Q fever. Many of these co-infections will cause the same similar presentations. You've just got to learn them a little bit to get a sense of these resistant symptoms. It could be some of these other co-infections. 3 days ago, one of my patients came in with a high agglutinating antibody, 1 to 160 for brucella. He had true brucellosis. We just picked it up 3 days ago before I came down here. And now he's going on basically doxycycline, rifampin, and Septra. These are some of those classic double intracellulars with Septra for some of these bad cases, but sometimes you do need streptomycin or Gent. We talked about the viruses. I don't really need to go into much. Just know that you can reactivate your underlying viruses like Epstein-Barr, herpes virus 6, CMV. You can reactivate your viruses when your Lyme is in your body. So you should check some of these viral titers. And I talked to you about Powassan virus. I don't really need to go into this in detail. The only thing you really need to know about Powassan at this point is, as I said, 15 minutes of a tick bite, it can be transmitted. New onset fevers with seizures with focal neurological findings. And again, we're finding this now throughout the Northeast. So we're finishing up here. So how do you figure out if someone has Lyme and a co-infection? So Lyme disease, again, migrates around the body, comes and goes, intermittent tingling, numbness, burning. Women flare up right before and after their menstrual cycle. Symptoms are better or worse with antibiotics. Babesia, malaria-like. Day sweats, night sweats, chills. Ehrlichia, anaplasma, Rocky Mountain spotted fever, low white cell counts, low platelet counts, elevated liver functions. Bartonella, ongoing symptoms despite prior treatment, with very bad headaches, very bad neurological symptoms with encephalopathy, neuropathy that doesn't get better, eye problems that are not getting better, and mycoplasma with a lot of inflammation. So these are multisystemic illnesses. I'll show you this afternoon how to use this this screening questionnaire. We'll talk about, again, the bands this afternoon, which I talked to you about earlier. They're very specific that you have Lyme. And again, you can use PCRs and culture to get the diagnosis. But there are really problems with these testing, not just for Lyme, but for Babesia. Thank you. And we really need to expand the net for these other tick-borne infections. So for Lyme, when there's not too many co-infections, Lyme has cell wall forms, cystic forms, intracellular forms, and biofilms. So you could use a penicillin with Plaquenil Zithromax, or an cephalosporin, Omnicef, Plaquenil Biaxin, or intramuscular bacillin, Plaquenil Zithromax. All these regimens will work for Lyme, but if it doesn't work for a patient, you've got to use these double intracellular regimens that I just talked to you about, because Bartonella, Mycoplasma, Ehrlichia species, Brucella, Tularemia, they're all intracellular, Q fever, intracellular infections. So if you just rotate your intracellular drugs like doxyrifampin with or without Septra, you're going to cover Q fever. You're going to cover Brucella. You're going to cover Tularemia. You're going to cover Bartonella. You don't have to worry about how unreliable the testing is. You just have to know how to rotate the regimens if they're not getting better. So this is kind of an idea of how you put this together. It's almost like going to a menu in a restaurant where you kind of put together, one from column A, one from column B, one from column C. Your patients have Lyme, they have Babesia, and they have BART. So you can use a Lyme regimen, and you can add a drug to cover BART, and you can add a drug to cover Babesia. The real trick to all of this is you just can't mix drugs that affect QT intervals and prolong it on a cardiogram. So Lyme MSIDS is a symptom complex of Borrelia organisms and multiple co-infections. We really need to change the term chronic Lyme because these are patients who have Lyme with co-infections. They also have immune dysfunction, inflammation, environmental toxins and heavy metal burdens. They can't detoxify well. There's nutritional deficiencies, hormone abnormalities like low adrenals and low testosterone. They don't get to sleep. The mitochondria don't work. All of these 16 points is what I'm going to be discussing this afternoon, but this is why they don't get better. So Lyme MSIDS would better define these patients, so you need to think multiple overlapping factors and co-infections being one of the main reasons they're not getting better. And this is what we're going to discuss this afternoon, these 16 different points. And again, this is all described in my book in great detail. Wisdom is the marriage of knowledge and experience bound by compassion. The last slide I always finish off with is, you've got to have compassion for these sick and suffering people that go to 16 to 20 doctors where they're told there's nothing that any doctor has done for them. They're diagnosed with chronic fatigue, fibromyalgia. It's all in your head. What I usually tell them is what's in your head is usually Borrelia, co-infections, and neurotoxins. That's usually what's in their head. These tests are unreliable, so have compassion and treat these patients as if you were going to treat a family member, a brother, a sister, a daughter. Treat them the way you would treat a family member. Don't give up. Keep looking for the co-infections, and you will find these patients will get better. Thank you so much for your attention.